alternatives, who talked about their decisions to forego care, to ration medicine, to postpone important surgeries, or to deal with sky-high bills. These are anecdotal examples, but they're reinforced by on-the-ground market statistics. In 2017, U.S. healthcare expenditures were $3.5 trillion, about $10,000 per person. A chief driver of these increasing expenditures were increasing healthcare prices, particularly from hospitals. At the same time, real wages for medical technicians and health aides stagnated or declined, despite increasing educational attainment and job growth. And I just want to emphasize that point because we talk a lot about prices and patients and patient experience, but it's really important that we not forget the other side of the coin in terms of wages and the role for healthcare workers who are providing the care that we all need. So these troubling trends demand that all of the stakeholders take a step back, reevaluate our policies and tactics, and consider enhancements or changes that each of us can make in the healthcare provider markets. And this starts with competition. When we're considering antitrust policy changes, the first thing I think we need to do is ask, what role does the FTC play and how well are we performing? It's really easy to point fingers when you see a problem in markets, and I see finger pointing all the time. People say, we're not doing antitrust enforcement anymore. Or we say, it's not the enforcer's fault, it's somebody else's fault. This is sort of endemic. Whenever we're trying to solve problems in Washington, it's always somebody else's fault. And when everything is always somebody else's fault, we have a really hard time coming up with what actual solutions look like. If we don't identify correctly how we got where we are and what the specific problems are, then any solution that we identify isn't actually going to solve those problems. So the first step for me, both in my role at the FTC and in speaking about it today, is to sort of take a look back and figure out how did we get where we are today? What is the FTC's role and track record in healthcare antitrust enforcement? And what concerns remain despite the best efforts of the FTC and other enforcers? The FTC has a long history of challenging anti-competitive mergers in the hospital space. From 2000 to 2018, nearly half of FTC merger challenges involved the healthcare industry, and a significant portion of these challenges focused on healthcare providers generally and hospitals in particular. But the story of the FTC's healthcare enforcement efforts, healthcare provider enforcement efforts, is one of significant obstacles that the agency has had to overcome. After winning court cases in the 1980s and early 1990s, the FTC and other enforcers suffered a string of 7 consecutive court defeats in merger challenges. That's a big deal, and it has a lasting impact on thinking about how to bring cases. In these cases that the FTC lost, they lost generally because the courts credited the parties' geographic market definitions and the parties' arguments regarding their nonprofit status, more specifically that a nonprofit merger can't be anti-competitive, which doesn't actually make any sense. So the FTC did exactly what it should do in that circumstance. It took a step back and said, let's look closely at what happened and let's figure out how we can do better. When Tim Muris was chairman and Joe Simons, now the chairman, was the director of the Bureau of Competition, along with Mike Vita in the Bureau of Economics, the FTC undertook a merger litigation task force and a merger retrospectives program. Through the retrospectives, the FTC was able to demonstrate there were flaws in the court-credited approach to geographic market definition, and that mergers with nonprofits can be anti-competitive. Not terribly shocking, but important to demonstrate with real evidence. The FTC also identified insurer testimony as a compelling way to show price effects and anti-competitive effects for consumers. Since then, the FTC has successfully blocked numerous hospital mergers, but not without some resistance. In fact, 2 of our court victories came only after losing at the district court level. So we won at the circuit court, but we lost at the district court. That's important to me as a metric. If we were only bringing cases that we were winning, that would suggest to me some systemic under-enforcement. If we are occasionally losing cases, that means that we're not just relying on the sure thing wins. But that also means that we continue to face significant litigation risks. Even with those risks, the agency is looking to stay aggressive. And I will tell you, I spent a lot of time over the last year with the staff in the division that brings the hospital merger challenges, and they are extremely dedicated. They work incredibly hard to uncover evidence, to figure out how to challenge mergers, where problems might lie, and I think that work deserves a lot of credit. So we're working hard. We figured out how to win some cases. But at the same time, recent research suggests that there are significant concerns in the markets. Studies have found that mergers between nearby hospitals from 2007 to 2011 resulted in significant price increases. Some mergers between 2000 and 2010 resulted in lower wages for healthcare workers such as nurses. And there's limited evidence that mergers between competing hospitals realized the cognizable efficiencies that parties claim at the time of the merger. I'm going to go through and list some of the challenges that the FTC and other enforcers face in bringing and thinking about how to bring hospital enforcement cases. I'm going to give you a laundry list. I'm going to talk through all of them. It's going to sound like a long list because it is. Some of the challenges include resource constraints, limitations on pre-merger reporting, legal shield for conduct of nonprofit hospitals, high evidentiary burdens, the threatened loss of high-quality public data, and state laws and actions that inhibit enforcement. So now let me take each of these in turn. Let's talk about merger activity versus our resources. The fundamental problem we have is that these things are moving in opposite directions. Merger activity is increasing, resources are decreasing. Since 2010, average annual hospital merger volume increased by at least 50% versus the prior decade. And there are few signs that that high volume is abating. But at the same time, from 2010 to 2016, the FTC funding stagnated in nominal terms and declined in real terms. In other words, it looks like we're functionally flat funded, but what that means in reality is we have less resources because we have to account for pay and benefit increases. So we end up with fewer full-time employees. Our full-time employee headcount has declined over the last few years, even as the merger volume is increasing. And in fact, we have roughly 50% fewer full-time employees now than we did at the beginning of the Reagan administration. Not only is our staffing crunched, so are our non-staff resources, such as economic research and litigation costs. And the litigation cost point is really important when we think about merger enforcement, because since the 1980s, investigation and litigation discovery has expanded exponentially. And critically, economic analysis is increasingly important in bringing merger challenges, and what that means is exorbitant expert witness costs. You can't win a case without a really expensive expert. And the experts demanding significant fees have stretched FTC resources really beyond where they can manage. So that's resources. Let's talk about merger reporting. Many relatively small transactions need not be reported in advance under the HSR rules. Some of these transactions may be anti-competitive, but the parties can consummate the mergers before the agencies could review and challenge them. Recent research suggests that the cumulative value of small deals is between $30 and $40 billion since 2000, and a disproportionate number of these small deals involve healthcare. The FTC has a track record of suing to block consummated deals, but doing so delays relief, prolongs harm, and makes remedies more difficult to achieve. We have a statutory obligation to stop anti-competitive mergers in their incipiency, and pre-merger reporting helps us vindicate our incipiency mandate. Now let's talk about the nonprofit exemption. The FTC does not have jurisdiction to review the conduct of nonprofit hospitals. We do have jurisdiction to review all mergers, but we can't police the practices of a merged nonprofit hospital, and that's more than 45% of all U.S. hospitals. So, for example, if we can't block a merger between two nonprofit hospitals, but the newly merged entity engages in anti-competitive practices, the FTC is stuck on the sidelines. That means that all the FTC expertise that we gain in the course of the merger review can't be deployed alongside DOJ and state enforcers. Next, let's talk about the evidentiary burden and the insurer role. So this is one of the things that was really interesting to me when I came to the FTC and started looking at hospital cases in particular. It came as a surprise to me, and I think many Americans would be surprised by the type and extent of evidence that courts expect, and particularly by the reliance that we place on insurance companies to talk about harm from mergers. Just as a consumer, as a patient, I would not immediately think of insurance companies as the best proxy for patients. It turns out, actually, that insurance companies, as the payers to hospitals, do provide a really rich well of data for us and can provide really compelling evidence about the price increases that hospitals can demand and the effect of merging hospitals on prices. And the Anthem Hartford example that I talked about at the beginning sort of demonstrates that writ large. When insurance companies are negotiating over prices with hospitals, if they fall out of contract, the patients pay higher prices. If the hospitals successfully demand higher prices, the patients pay higher prices. So the insurance role is really critical. And it may be the best third-party proxy we have for competitive effects to date. But insurers may not be the best positioned to observe all the harmful effects of mergers. And more importantly, insurers have to continue to contract with hospitals. They may not be eager, is perhaps the best word, to provide evidence, to get on the stand and to testify against the hospitals with whom they're going to need to have an ongoing relationship. That's a problem in antitrust enforcement generally, but it's one that I think we need to think about in hospital mergers specifically. Okay, next, the insurance industry restriction. The FTC is statutorily prohibited from studying the insurance industry without an explicit request from Congress. Why? Because in the 1970s, the FTC issued several highly publicized insurance industry reports with significant recommendations for reform. In 1980, months after former Chairman Perchik's testimony on life insurance industry concerns and his proposed solutions, the FTC was stripped by Congress of its independent authority to study the industry. Today, this restriction continues to constrain FTC research and advocacy activities. Now let's talk about data, available data, and I'm going to talk particularly about the Healthcare Cost Institute. You're going to hear a lot more about this from Niall later, but I don't think we can overstate, how important rich, accurate public data is to understanding markets and how they are operating. And our future research opportunities right now are potentially imperiled by a lack of pertinent data. Today, HCCI gathers insurers' claims data and makes the data available to independent researchers, including several to whom I referred earlier. But HCCI depends on voluntary participation by insurance companies. These efforts are laudable but vulnerable. United is backing out. Humana has signaled that it will back out. This is a deeply troubling development. I strongly urge United and Humana to maintain their HCCI partnerships, and we shouldn't stop there. We shouldn't just keep the people who are in. Other insurers should get into the system too. We can only benefit from rich, widely available data, and if they don't want to share the data, it does make you ask, why? What are they afraid of us finding out from the data that's out there? Finally, let's talk about the states. Federal enforcers periodically face challenges in our enforcement from the states. To be sure, states play a vital role in enforcement. Pennsylvania, Idaho, North Dakota, Illinois, Virginia, Ohio, California, and Washington have all joined FTC merger challenges or brought independent actions recently. States gather and share hospital and insurer data with the FTC, but sometimes our enforcement efforts are not in sync. Occasionally, states adopt merger settlements that inhibit more aggressive federal enforcement. And several states have passed certificates of public advantage, or COPAs, that immunize hospital mergers from antitrust enforcement. Recently, COPAs stopped FTC from challenging 2 mergers that created near monopolies, including one where FTC had already filed a suit to block the merger. Today, Texas is considering legislation that could exempt rural hospital mergers in the state from scrutiny. COPAs intend to tackle legitimate concerns and often require conditions to mitigate merger effects, but sometimes they lapse or are repealed, and then they leave a merged monopolist hospital with no regulatory oversight. There are way too few empirical studies analyzing whether COPAs perform as well or better than a competitive market. Okay, that was a laundry list of challenges. So now the question is, what do we do about it? What do we do in the situation that we're in? The challenges are significant, but they shouldn't deter the FTC efforts and a creative use of our current authority and our resources. The important work that we do and these questions that we're asking gives us the perspective to consider what can we do differently or better with existing resources and authority. Where do we need to turn to Congress or others for help? I made the point earlier about finger pointing. Everybody wants to point fingers and say it's somebody else's fault. I think we have a responsibility to figure out what part of it is when I said that we need to think about what we can do differently and better, I mean that really sincerely. I'm going to identify things that I think need to be done outside of the FTC, but I also think we need to take ownership about where we can work harder or use our learned experience to improve our enforcement efforts. And that's what the hospital merger retrospective program that I referenced earlier did. Some of the FTC's most significant contributions have come from our authority, the exercise of our authority to study markets. Retrospectives help us hone our understanding of how to resolve tough cases and may allow us to pursue consummated enforcement. So I think we should conduct a new round of retrospectives, targeting particularly recent close call hospital mergers, consistent with the commission statement in the B.I. Leahy matter. I think we should target mergers where COPAs prevented enforcement, and especially vertical mergers, such as hospital-physician mergers. I'm particularly interested in the cases where there are new structures, sort of not your traditional horizontal consolidation, but new arrangements of market participants. At the same time, I think we need to continue our program of aggressive enforcement. We should push the envelope and not be afraid to bring cases, especially with these creative new structures that I referenced. I'm sensitive to the issues of litigation risk, but our job is to identify the right outcome and to fight for it. If we never bring a case, unless it's a sure thing, we are almost certainly under-enforcing. On top of that, and given the concerns raised by recent research and the persistently high volume of merger activity, it's an important moment for Congress and the FTC to rethink the agency's resource base and scope of authority. As a starting point, we should increase funding to bring our staffing levels in line with the levels at the beginning of the Reagan administration. We should increase merger filing fees, which have not kept up with inflation. We should evaluate tools to better measure agency workload and allow resources to increase as workload increases. In other words, we shouldn't be in a situation where merger volume is going up and our resources are going down. Those should be pegged to each other if it's possible. Once the agency has resources in line with its workload, we should consider pre-merger reporting revisions to facilitate efficient pre-merger reporting and review of smaller transactions. Pre-merger reporting is very resource intensive, so any expansion of reporting authority should not be made without a significant expansion of resources. But I think we should also think about whether the traditional triggers for reporting, such as transaction size, should be augmented or modified. There may be better ways to ensure that smaller transactions that raise concerns are reported without flooding the agency with filings for mergers that don't raise concerns. Of course, if you're going to think about creative structuring, you also want to do it in a way that merging parties can't creatively structure to avoid reporting. So this is not an easy question, but targeting a close mapping between the filings we get and the problematic areas would be a really useful exercise. And if insurers insist on terminating their HCCI partnerships, Congress should consider policies to facilitate ongoing access, such as creating nationwide data clearinghouse and mandating insurer data submissions, as long as that data is maintained consistent with privacy protections. We need data to be available to public enforcers, academics, and other researchers addressing important questions involving healthcare markets. Congress should repeal the nonprofit exemption for the FTC and the limitation on insurance industry studies. That way, the FTC could go after conduct involving nearly half of the nation's hospitals, including conduct discovered in merger investigations. And we could proactively study market trends and practices affecting healthcare markets. And finally, Congress should consider legislation that would simplify the evidentiary burden on the government and heighten the burden on parties in merger litigation generally and hospital litigation in particular. This would strengthen the agency position when it finds significant evidence of harm without offsetting efficiencies. And it would reduce the risk that impediments to evidence gathering permits anti-competitive mergers. What I just said sounded very technocratic. It's a really big deal. Shifting burdens, shifting presumptions in mergers is a huge deal. And I recognize that it's a big deal. At the end of the day, what it does is it prioritizes type 2 over type 1 errors, right? It says, let's choose to block mergers that might not be anti-competitive rather than let through mergers that are. And currently our enforcement prioritizes the other way. I think I am comfortable with shifting that error risk presumption at this point, particularly in the case of hospitals. Finally, the states. States can and should continue to play important complementary and supplemental role to federal enforcement. Recently, several states sought training and support from the FTC, and we answered. In April, the FTC convened the first of several healthcare litigation workshops. Representatives from 40 states attended. States should continue to work as active partners in blocking anti-competitive healthcare provider mergers, and we should encourage actions that are consistent with pro-competitive enforcement goals. And wherever possible, states should resist efforts to immunize anti-competitive hospital mergers. Recently, Montana passed a bill to prohibit COPAs, and I hope states that do not have active COPAs follow Montana's lead. States with active COPAs should work with the FTC to study how COPAs affect prices, quality, and wages. The FTC's COPA assessment program welcomes input, and in June, the FTC will host a COPA workshop, so I encourage all stakeholders to participate in that. States should also consider adopting other competition-enhancing policies, including state-level pre-merger reporting requirements. So Connecticut has established pre-merger reporting for hospital and physician group mergers. Washington and Florida are also considering pre-merger reporting laws. States should lower barriers to entry or expansion. So, for example, where applicable, repealing certificate of need laws. States should promote alternate forms of care delivery, such as adopting regulations facilitating telemedicine. And finally, states should expand state insurer claims data collection and dissemination. In conclusion, affordable, quality health care is vital to American patients. Fair wages are important for all workers, including healthcare workers, and we can't deliver these goods without competitive markets. In order to promote competitive markets, antitrust enforcers must remain vigilant, we must remain aggressive, and Congress and the states must outfit our law enforcers with the necessary resources, capabilities, and authority. Thank you very much.
Hi, everyone. I'm Emily G., and I'm the health economist here at the Center for American Progress. I first want to say a very big thank you to Commissioner Slaughter for sharing with us the work the FTC is doing and some ideas for what the FTC could do better and how Congress and states could also help support efforts in antitrust. I want to take about 10 minutes to open the floor to questions from the audience. I think, Commissioner Slaughter, you provided us with a lot of terrific ideas and also a sense of the challenges that you're up against in protecting patients and healthcare workers as well. So before I look for hands out in the audience, I do want to say that we have a mic here, which Diane from our team here will be handing out. Please wait till the mic gets to you. In addition to the audience here, we've also got folks watching via the webcast, and they won't be able to hear you unless you're on the mic. When the mic does get to you, please state your name and affiliation. And the last thing I ask is, please make sure your question is actually a question. Thank you. There's a couple in the back there.
Hi. I'm Megan Mortimer with the American Dental Association. Besides mergers, acquisitions, and policies surrounding that, beyond that, in terms of other anti-competitive conduct, how does the FTC, or how do you, feel about repeal of the McCarran-Ferguson Act, and would that help you in your efforts overall in terms of investigating certain anti-competitive behaviors?
Yes, I think it would be helpful. I mean, as a general matter, I think limitations on what we can look at, what we can study, and where we can enforce don't have a lot of benefit. They keep us from doing important work, particularly where lines between industries have become blurred over time. So I'm all for it, getting rid of it.
Hi. Hi, I'm Scott from Representative Steve Stiver's office. So there's a bill that's very popular in Congress, the Competitive Health Insurance Act. It was passed last Congress in the House and didn't get taken up in the Senate. And I think the same thing's going to happen apparently. But it basically excludes insurance groups from the I forgot the name of the bill, but the one but only for health insurance. And I was wondering, like, the CBO said it would have a very limited impact on sort of the budget overall. And do you sort of agree with that sort of limited assessment of what that bill could do, or do you not have enough information yet to know?
I definitely don't have enough specific information about that bill to opine on it. I will tell you, I spent a lot of years working in Congress, and I perhaps have a cynical view of CBO assessments generally. I think they do the best work they can with the information that they have, but we should evaluate legislation on its merits and not take CBO scores necessarily as doctrine.
Yeah, I'm Carl Pulzer, and I have a project called the Center on Capital and Social Equity. It promotes economic inclusion. But my question has to do with, it's based on experience in Northern Virginia, advocacy I did, where the certificate of need law seems to conflict with the theory of a market, and that the certificate of need law that they still have, some states still have them, it sort of, to me, fits a single payer system where you're just going to have as much supply as you need and you stuff it in a sausage. If you're going to have competition, you're going to have surplus supply. Because the HMO is going to come. If the HMO has 30% of the market, and if there are two hospital systems, and if one can't, they don't come to agreement with one, and they go to the other, they can overload the other. So I just find this whole conflicting system that we have in Virginia crazy. But anyhow, I can't go into details, but it's, yeah, there are two conflicting systems there. I don't know if that's part of your analysis or?
Well, to the extent that the question is, how do we deal with the fact that sometimes state laws conflict with broader federal antitrust goals? That's absolutely one of the challenges that I think that we need to grapple with, which we need to grapple. Certificate of need laws, COPAs, all of these things. There may be good reasons outside of competition to put them in place. And I don't want to put myself in the shoes of all of the state legislators or state enforcers who are thinking about them, but we should take seriously the effect that they have on competition, and particularly in healthcare markets, and make sure that whatever goals are being achieved are doing it in the way that is least restrictive to competition as possible, if they're even being achieved, and make sure that they're being achieved, and that they're not just an excuse to entrench incumbents or enable monopolists.
I think we have time for about a couple more questions.
Hi, I'm Bob Liebenloft. I'm with Hogan Lovells, and I used to do a lot of work in healthcare. I headed the healthcare division when I was at the FTC in the 90s, when we back then lost a few of those cases. So I'm very aware of the issues, and I appreciate your summary. One question is, the FTC focus right now on hospital mergers is on the impact on prices for inpatient hospital services. And that market is becoming less important, and there's a lot more innovation going on as care moves outpatient or population health and so on. And the question is the staff focusing as much as it should be on the impact of a deal, either positive or negative, on innovation in healthcare financing and healthcare arrangements beyond just inpatient services?
Yeah, well, so I will tell you, in my experience in talking to staff dealing with these cases, they are looking at all of the kinds of services that a hospital provides and trying to identify potential overlaps or potential problems, identify whatever efficiencies the parties are claiming, not just inpatient services. So at least from my perspective, they're asking those questions. We should always be thinking carefully and making sure we're accommodating and adapting to how the market is changing, and not asking the questions that were relevant 5 years ago or 2 years ago, but making sure we see how the market is operating now. But I would at least represent from an intent perspective, it seems pretty clear to me that the staff very much intends to be capturing that.
I'm Eileen Applebaum at the Center for Economic and Policy Research. So my question has to do with the fact that private equity has stepped up its investment in healthcare. Their model is very different. They don't concentrate in a single health market. They buy hospitals that are dispersed across a number of states. I'm thinking about CHS, for example, in particular, Community Health Services, which bought up tons of rural hospitals, tons of suburban hospitals, overloaded with debt, now fighting off default, by selling off hospitals, sold off 38 rural hospitals in one fell swoop. They're down to 27 now, and the rest of them are struggling because they've been loaded with debt. And I just wonder if the FTC is paying any attention to this kind of merger activity, which also has price impacts, because think about it, CHS is the largest for-profit chain in America by count of hospitals, even bigger than HCA. And it negotiates, for example, with United Health across the country. And so it has the same ability to drive up prices for insurers that you have when hospitals are concentrated in a geographic area. So my question is whether there's any attention to this at the FTC.
Yeah, so the question, I think generally, I heard two parts of it. One is, are we thinking about cross-market issues? Are we thinking about mergers that don't just happen within one geographic market? And the answer to that is definitely yes. I don't think that there is consensus about how those cases could be brought or proven, but I think that there is a lot of awareness of the trend and the challenges that it posed. And then the other part of the question sounded like it was about the role of private equity in particular and the business model of sort of coming in, purchasing, loading up businesses with debt to make a profitable exit that benefits the holding firm but not the company that they have purchased and perhaps discarded. And yeah, I think that's a really disturbing trend, not just in hospitals, but across industries, something that we need to look at really carefully.
Commissioner Slaughter, thank you very much for your thoughtful answers to these great questions and for joining us today,
Thank
and
you.
as well for your work at the FTC Advancing Antitrust.
Thank you.
Michael, I've got you in the middle, if that's all right. I've got you in the middle, or here, thanks. Yeah, thank you. I'm very pleased to welcome a panel of esteemed experts who I think the nice part about this is we've got a very wide range of views here to talk about what consolidation in healthcare means, not only for patients, but also, and from a policy standpoint, but also what it means for workers as well. So for about the next hour, I'll be joined by our three panelists here who will introduce, and then we'll dive into a discussion here, and we'll save some time at the end, again, for questions from the audience. So immediately next to me here is Kyle Arnon, who manages the Center for Collective Bargaining at the American Federation of Teachers, which provides bargaining support to AFT affiliates, which include healthcare sector affiliates. In the middle is Michael Kadis. He's Director for Markets and Competition Policy at the Washington Center for Equitable Growth. Prior to that, he worked for Senator Amy Klobuchar and practiced as an attorney at the Federal Trade Commission. And then on the far end of the podium here is Niall Brennan, who's president and CEO of the Healthcare Cost Institute, which we've been talking about already quite a bit this morning. And he was previously the chief data officer at the Centers for Medicare and Medicaid Services. So I want to kick us off by taking a deeper look into some of the evidence that Commissioner Slaughter alluded to on provider prices. We're living in an era of rapid consolidation, not only in the hospital industry, as she was talking about, with a merger boom happening despite FTC's renewed efforts to challenge some of those cases. And we're seeing study after study that consolidation increases healthcare prices. In fact, there was a RAND study that came out just last week showing that commercial prices, that is, prices that are paid by a typical employer-sponsored insurance plan, are 2.5 times that of what Medicare pays. So I want to kick us off with Niall. Can you talk a little bit more about what HCCI does? You've amassed a huge amount of data that's done an incredible public service in understanding, helping us understand about the prices that we pay for care. Can you talk about some of your analyses and the research that you supported externally?
Sure, thank you to Commissioner Slaughter for highlighting our plight. We've, I don't know, done our job so well that we're actually losing data, not gaining it. But we currently still have data from Aetna, United, Humana, and Kaiser, and that represents about 43 million folks with commercial insurance, employer-sponsored coverage. We do have some folks with individual market coverage and also MA. It was frankly astonishing for me to come from a long career myopically focused on Medicare spending and utilization and Medicare issues and start to understand this commercially insured population and start to realize that for all the progress we're making, or we think we're making, with public sector programs, trends are absolutely going in the wrong direction for folks with commercial coverage. And let's just remind ourselves that 160, 170 million Americans still get their health insurance through their employers. When you talk about the largest single block of Americans with health care coverage, it is this population. And we are seeing Uwe Reinhardt's famous words in action. We are seeing relatively unconstrained price growth across multiple healthcare sectors, but particularly hospital inpatient and prescription drug care. This is all available online in our reports and issue briefs. We're fully transparent. We have had work featured recently in the New York Times that dives all the way down to variation in commercial prices for specific services like C-sections and the like. And nationally, there's 4- or 5-fold variation in the price for C-section, for example. But even in any given metropolitan area, there can be 2-, 3-, 4-fold variation as well. So I think we have to take a step back and ask ourselves, why is this happening, and how sustainable is it? And if it's not sustainable, what are we going to do about it?
Michael, can you talk more about the connection between prices and consolidation and competition, and what sort of things would, say, an FTC analyst look for in trying to decide whether to approve a merger or not?
Sure, absolutely. So this is really a market, an industry where we have a tremendous amount of research, far more than most industries. And not only do we have a lot of it, it's pretty consistent that consolidation leads to higher prices. And there tends to be very little evidence that consolidation leads to improved quality. So what the agencies I tend to look at based on the cases they litigate is they're going to look at how the merger changes bargaining power between the hospitals and the payers. What are the impacts of that likely to be? And then they finally also are looking at what are the claimed efficiencies. And a lot of their investigation goes into trying to weed out whether the proposed efficiencies, whether they're really going to deliver better care. And I haven't done hospital mergers since when Bob Liebenhoff was there, so he can blame me for the losses. But I marvel at the staff has to go through. It's like recreating the wheel every time. This merger will improve. We're going to save thousands of lives, even though we know empirically the research says no, consolidation really isn't all that necessary to improve quality of care.
Right, and I think quality and price are often two of the things that we talk about the most, but there are also some potential harms from consolidation on the worker side too. And Kyle, could you talk more about your work and what you've seen in the healthcare space?
Yeah, I think there's the global view too. So there is a trade-off when I go into bargaining with our AFT affiliates. There is a trade-off between wages and health benefits and retirement, right? And so when premiums for healthcare go up 6 to 12%, I've seen 12% several times in the last few years, there's less money because employers tend to think of it as a pool of money available to compensate their workforce. There's less money available for wages. So I see it in K through 12, in higher ed, all the time. I think there is a specific set of challenges for healthcare and the impact of consolidation, but that's just sort of the broader view. For healthcare, the challenge for us, just to give you a baseline, healthcare is interesting because in the private sector, there's been a decline in union density over time, but in healthcare, it's actually risen over the past 30 or 40 years, and about 1 out of 5 healthcare workers are now represented by a union in the U.S. in the private sector, and that's pretty good. When you have consolidation, you have an agreement with one hospital, might be small, and it gets purchased by a larger health system. You may have gone from 100% union density, in which you have pretty good bargaining power in that case, down to 10, 20% union density in that facility. And you will have less bargaining power relative to the employer. And they will also have more resources to marshal against the bargaining drive. So there's that. There's also, the collective bargaining agreements have 4 corners. There are things that are in and out of our agreements. And part of consolidation isn't just bigger systems. There's been a reconfiguration of the healthcare system in general. So work that was done in a hospital may be moving out to an ambulatory outpatient setting. Those folks, and I think there are a lot of good reasons why that's the case. It may be cheaper to perform that work in the outpatient setting, but a lot of times that takes people outside of the bargaining unit. And outpatient settings, ambulatory settings, tend to be lower compensated work almost across the board. If it's the same, if you do a comparison of RNs, outpatient, inpatient, outpatient RNs are paid less almost universally. The next challenge we have is just new job titles. So there are job titles that didn't exist in the past. With this new healthcare system to coordinate between hospitals, physicians' offices, ambulatory settings, patient care navigators, coordinators, and a lot of times these are RNs and other certifications that have existed, but they're not also represented by the bargaining unit. And so there is a sort of death of 1,000 cuts with all this reconfiguration and consolidation. And the challenge for us is just trying to make sure that as the healthcare system changes and reconfigures, that we represent the broadest possible number of workers.
Can I just jump in? The other thing that I think builds right off, you were saying what Commissioner Slaughter touched on. The other thing we're seeing in this industry is not just that consolidation leads to higher prices, it leads to stagnating wages. And there's been a lot of activity in the antitrust world and research about monopsony power, which is basically when the buyer has the market power as opposed to the seller, right? And there's been some concern that some of these studies are not sort of empirically valid, at least from traditional antitrust economics. So the one study that everyone really likes is actually the one Commissioner Slaughter referred to, which looked at hospital consolidation and how it stagnated the wage for professional healthcare workers. Similarly, the one case litigated where this really came up was an insurance merger, right? So what you really have is on both sides of the transaction, when you get consolidation, the people using the hospital are worse off and the people providing the care can be worse off. So I just thought that was an important point to make.
That's a great point. I want to pick up on another thing that Kyle mentioned too, was the migration of patients toward outpatient departments and the changing nature of the hospital industry. At the same time, I think outpatient prices have been growing much faster than inpatient prices in other areas of healthcare. So now, can you talk a bit about what the connection is between prices and value, and is there?
Well, I mean, this is one of my favorite topics in the sense of I think value-based care in and of itself is a perfectly acceptable intellectual construct, but I firmly believe that one of the reasons people want to talk about value-based care or quality or transparency is that they're much easier conversations than having difficult conversations about price and unsustainable prices and unsustainable price growth in healthcare. One of my favorite examples is all the value-based care in the world is not going to save us if whatever savings we achieve from slightly better quality, slightly reduced readmissions, slightly lower ER visits, whatever it is, if the price on the residual care that's always going to be provided is increasing at such a rate that not only are we staying afloat, we actually are, continuing to sink. You can look at really any random sample of services across the healthcare system. We've done some work with Sarah Cliff at Vox. Well, I guess she's at the New York Times now. Over the last year or so, just looking at facility fees in emergency rooms in the U.S. And when you see the price, the negotiated rate between providers and payers for ER facility fees increasing by 85, 90, 100% over a 5 or 6 year period. I just don't know how you can square price increases like that with, kind of broader aspirations that value-based care is going to save us.
Michael, I would love for you to talk a little bit more about the role of the FTC. I think, it often pops up in the news relative to merger challenges or merger blessings, but a big role is also monitoring conduct. And is there a role for federal enforcers, be it FTC or DOJ, to stop these sort of abusive practices like balance billing?
So currently, right, the FTC can look at conduct only if it involves a for-profit hospital. Now, state attorney generals can look at it. The Department of Justice can look at it. But I think it makes little sense to be cutting off the enforcement resources. Again, going back to the fact that it's every day essentially you hear of some new practice that seems to be causing higher prices. Now, some of them may not be antitrust violations, but we should have the most resources possible to investigate those, conduct by hospitals, particularly where they have monopoly power, or insurers as well, or providers, right? Like that in some sense, looking forward, this is really critical because we've already had lots of consolidation. It's not clear you can turn that clock back. That should mean that going forward, we expend more resources making sure nobody is abusing market power that they have.
And Nyla and Kyle, in your work, have you seen that nonprofits, of which there are many in the healthcare sector, behave differently either on the worker or the pricing side? Are these more benevolent institutions that deserve maybe less scrutiny than others are getting?
Go ahead, I'll go
I'm
next.
certainly not aware of any dramatic differences. Look, I'm not tracking every healthcare system in the country very closely, but if you look at the pricing structures or even the reserves that many of these nonprofit systems have, they don't seem to be hurting for resources.
I would say on the worker side that there is a definitive difference between nonprofits and for-profits, and there's also a whole subclasses within nonprofits. But in my experience, for-profit hospitals, they could have, just think of the logic of it. They could have invested that money somewhere else, right? And they didn't. They went into healthcare, and they went into healthcare because they thought they could get a higher rate of return in healthcare than they could in the stock or bond market or somewhere else. And they also have to pay taxes. Nonprofits don't have to pay taxes. And they have to pay their investors. So the money has to come from somewhere. And it tends to come from lower staffing and worse wages and benefits. They're way more hostile to unions in my experience. They're way more savvy with their billing. And they're more predatory in their collections. One example I can think of, I don't want to name the system, but New Jersey has a law that if you have an emergent situation and you go out of network, the insurer is on the hook for that visit. And so what has happened in New Jersey is that some hospitals have, of course, tried to stay out of network and take advantage of the fact that they don't have to balance bill patients. They can send the bill to the insurance company, and there's no cap on the charge they can send, right? Because they're not in network. There's no pre-negotiated rate. And so I've seen some of these differences so I think that there's, not the nonprofit world is a totally different thing too, and I think that's a whole different conversation. But yeah, I think there are some big differences between for-profits and nonprofits.
I just wanted to pick up on something that Kyle had said earlier, and a lot of the conversation so far has been focused on sort of hospital-to-hospital consolidation, but there are other waves of consolidation in the industry, specifically hospital physician consolidation. And Kyle is right that as care migrates from hospital inpatient to hospital outpatient, that has impacts of its own. But as physician practices are acquired by hospital systems and ambulatory care becomes outpatient care, that also has price inflationary impacts of its own. Literally, overnight, with the stroke of a pen, an office visit becomes an outpatient visit, and they're reimbursed at a higher rate.
I think that's a great point, that a lot of the mergers we're seeing, in the provider space and also outside it, has been vertical. So it's things like, pharmacies and insurers coming together, CVS Aetna, or, insurers and providers joining together. And so it's a whole different kind of competition and mergers that the FTC is having to deal with, in addition to the large volume of traditional hospital-hospital horizontal mergers.
Yeah. And again, getting back to the value-based care discussion, I mean, people are just acting in a rational economic way, but the accountable care organization framework in particular is really predicated on physicians trying to lower overall health costs through a variety of ways. But if I was a physician-only ACO, the place I'd be looking immediately would be to lower acute care spending. So if I'm on the acute care side, a way to protect myself against that is to own the physicians.
So we've talked a lot about the harms of consolidation. I want to try to talk a little bit more about, what rays of hope are there and what sort of solutions are we seeing. Commissioner Slaughter earlier alluded to some work that the FTC is doing to support states. I think there have been some interesting state cases recently, including the Beth Israel Deaconess Leahy merger. I think there are state laws in the books that can, be either pro or anti-competitive for healthcare providers. Can you share some things that you've seen that are interesting at the state level? Or I guess local level, even what maybe unions have done to help their communities?
Yeah, so we have had a lot of community partners reaching out to us in the past, couple of years, and I think part of it has been inspired by what has been happening in K through 12, where there has been a drive to negotiate not only over kitchen table issues like wages, health benefits, and retirement, but to bargain over things that are concerns to the community. So, if you look at the strike in LA, they were bargaining over more nurses in schools, more school counselors, better staffing, all of those things. And I think there's going to be a spillover effect in healthcare, and you can imagine all the different kinds of possibilities where a lot of the things the folks in this room and on this panel have studied are important also to the communities where we have a lot of union representation. So for example, I have seen several times where a hospital is purchased, and over the next couple of years, purchased by a system, their charity care spending goes down. Maybe it's a blip, maybe not. We have started thinking about proposals that we would introduce in bargaining that would basically require that hospital to maintain the same level of charity care from each year to the next year. And should they spend less on charity care, well, that difference they should use to put into a medical debt relief fund, because a lot of these hospitals have, sent some of their patients to court over collections. And you'll be surprised to learn that many of them are actually healthcare workers themselves. You would think that healthcare workers have really robust health benefits, and it turns out they don't. A lot of times. The last major strike in the healthcare industry was about 5 years ago, and it was in Minnesota, and it was over health benefits for healthcare workers. They were shifting workers from a low deductible plan to a very high deductible plan. So I think there's a lot of opportunity for unions to partner with community organizations, to be more imaginative in bargaining, to bring some of those issues about prices, about charity care, about closing of services, which often happens too. If you merge, part of the logic of merging, right, is that you can consolidate services. So instead of having 2 hospitals that have maternity wards that are 30 miles apart, well, you can close one of the wards and keep one open and refer patients from one hospital that need maternity services to the hospital that's 30 miles away. And community people care about those things. And I think we have an opportunity to bring it into bargaining, and we've just started that process.
So I would add, I think to the degree that there has been success in preventing consolidation, one can't underestimate the role of the state attorney generals in the following sense, right? These are not like the AT&T Time Warner merger where you're in DC and it's a big national or international companies. You bring a merger case, you can be, I tried one in Southeast Missouri. There was a physician-provider merger that the FTC challenged in Bismarck. These are in fairly small, remote areas. It would not be surprising that if there's one federal judge there, that federal judge, he or she, probably is in the same country club as the owners of the hospital. They probably play golf together. And what you're facing is, we know how to run healthcare. Don't let Washington in. And just when the states are willing to join with the FTC, the federal enforcers, it can be critical in the ability of changing the dynamics of the litigation and can really make a big difference. Also, ideally, I think we should be looking forward. I mean, at one sense, healthcare consolidation should be something state attorney generals should be, precisely because it's local. They should be able to act independently, and it's a great role for them, right? Because there's something wrong with the system where you have all this research that shows consolidation leads to higher prices, not many efficiencies. The FTC has engaged in more aggressive antitrust enforcement in this industry than any other. It has litigated more cases to completion in this industry than any others, and yet consolidation is continuing apace. So we somehow have to leverage those resources, and part of that can be state antitrust enforcement.
So let me ask a follow-up to that on the federal level, which is what more is needed, either in terms of resources or I guess persuading courts in order to step up antitrust in healthcare. Why are we not winning these cases, and why does consolidation seem unstoppable?
So it's not quite that. I mean, the FTC's been actually since I stopped doing hospital mergers, the FTC's been very successful. So that we then proceeded to go on to lose the next thing I worked on, which was patent settlements. So now I'm not there anymore. So that might solve the whole problem. But I think they have been successful. But it's important to think about what cases are going to litigation. So I just mentioned this Bismarck case. Right? This is Bismarck, South Dakota. It's not like you're traveling for your medical care to North Dakota or to Nebraska or farther. And so but in that case, the merger there would have created a monopoly in general surgeons, over 80% for OB-GYN, very high, same, I think, numbers on internal medicine. And so if that's the case, the government has to litigate to conclusion. That means that they are basically fighting off they're having to spend all their resources on the very worst mergers. That's got to tell you that there are probably a lot of cases where either they don't have the resources, or what the Bismarck case tells them is we can't win that case. So what you need to do is you need to change the judiciary precisely the way Commissioner Slaughter was talking about, so that they understand that competition matters, and that where we see where there's significant market shares, we should be more worried about harming consumers and workers through consolidation than in being worried about this may be the one unicorn merger that actually leads to mass improvement in quality.
I'm not going to be able to remotely build on the eloquence of that reply, but for me it's pretty simple. You've had an explosion of merger and consolidation activity at the same time when FTC resources, as Commissioner Slaughter said, have flatlined, which means they've effectively declined. So there's almost too many mergers, coming at the FTC, they can't litigate all of them. I don't want to put words into the FTC's, mouth. So, just by construct, they're not able, they don't have the resources to conduct the type of oversight that should be happening, then allied with kind of, state and other, judicial dynamics.
I think a lot of the evidence that we know about hospitals comes from outside researchers, such as Zach Cooper and Marty Gaynor, who were supported by HCCI data. Kate Ho, an economist that has done a lot of work looking at the harms from cross-market mergers, and Lee Moore Daphne. What sort of gaps in data resources exist for those outside the FTC and DOJ to better help us understand the theory of harm?
Well, I mean, we, for now, maintain one of the largest commercial databases available for public use, public good, and yet we only cover about 25% of the employer-sponsored population. So clearly, there is an opportunity, and again, really all the incentives in our healthcare system run counter to, trying to establish or build a database that contains the kind of information that we need, but the information that we need that comes from, proprietary sources and entities that compete for healthcare business. So I think we have to ask ourselves, do we want to actually, truly understand at a granular level what's driving healthcare prices, what's driving healthcare price trends in the United States? And maybe the answer is no, in which case organizations like HCCI will go away, and we'll know less about the healthcare system in 3 years' time than we do today. I mean, other economists have argued that, America is making a choice that, spending 20% of our GDP on healthcare is what America has chosen to do because it values healthcare above education or wage growth or jobs or security and the like. So I think we have to, we've been having this conversation for a long time. I started doing health policy back in the mid-90s when it was, healthcare spending was 12% of GDP, and it was absolutely unanimously agreed that this was totally unsustainable and couldn't continue. And now we're about to hit 20 over the next couple of years. So there's a little bit of a disconnect there.
So Kyle, I was wondering if I could ask you, picking up on this point about healthcare costs. I think some of the prices in the data, like Niles, are somewhat abstract to the consumer because what we pay when we go to the hospital isn't the list price for an MRI or even what the insurer gets charged for a C-section or for a joint replacement. But where consumers do see it is the insurance plans. Can you talk more about sort of the bite that insurance is taking and as a result of provider prices is taking out of people's paychecks?
Yeah, and it's different in healthcare actually than in education. If you look at education, the part of the pie that's gotten bigger of compensation that's been taking a bite out of wages is retirement for a whole variety of reasons. But in healthcare, it's been actually growing health insurance costs that have become the bigger part of the compensation pie over time. And I think that there's not really a whole lot of what we're seeing in healthcare is not much different than what you see in the economy at large. There's a proliferation of high deductible plans that have higher copays and coinsurance, narrower networks, and there's more cost shifting on the premium. So it may have been the case at one point in time that workers paid $0 toward their premium for their health plan, and I know of only one case right now nationwide where that is still true. It's a very large health system. But aside from that, I think we're seeing now in many cases healthcare workers are paying upwards of 20, 30% of their premium contribution. And in many cases, you have some weird combinations too where the provider, sometimes the insurance company, and so you can't go, there's a huge financial incentive on the worker side to stay within your employer's provider network. And in some cases, we are seeing healthcare workers saddled with debt that is from their employer. Now, those are maybe extreme cases, but I think that they're important and illustrative cases of the kind of craziness that goes on in the healthcare system, where there's kind of what we would call like a company shop situation, where you're both in debt to your employer and providing services to your employer as an employee.
Very interesting. I think, one thing that's been popping up a couple times is that, healthcare is inherently local. You can't go really shopping outside your hometown or outside your geographic region for healthcare. We're often also in situations where we don't have a choice of what provider to see, or when we're already in the hospital, we can't pick our anesthesiologist.
I mean, sometimes people are unconscious. How does an unconscious person shop for care?
Exactly.
I mean, the transparency has its limits. I'm not arguing against it. My prior tenure at CMS, I did a lot to push more transparency and open data. But let's be very clear that assigning responsibility for consumers and patients to control healthcare costs when all the other more powerful actors in the system have failed smacks of victim blaming to me.
Yes, I completely agree with that. I think, so another question related to sort of pricing and transparency and localness is that I think what's incredible is that you see this huge variation in healthcare costs. And unlike a market for a commodity where an apple is an apple in one market in New York City versus Washington D.C., healthcare isn't something that you can go and shop for. And so, Niall, can you explain more about the cost variation that you see? And are there certain characteristics of a place or an institution that tend to have high costs versus low costs?
I can describe it, but I can't explain it. Again, some of the work that we did that was released a couple of weeks ago, obviously the headline grabber was the negotiated rate for just a CBC blood test, and nationally the cost of that blood test ranged from about $10 to almost $1,000. Like, there's just literally no rationale for that, and that's after we lopped off the bottom 10 percentile and the top decile of the distribution, because we didn't want to be accused of playing games with outlier values. I think a lot of it comes down to, look, the healthcare system is unique. There's all the things we learned in Econ 101 or Health Econ 101, information asymmetry, moral hazard, et cetera, et cetera. But the system is built so that predatory pricing can occur, and people just don't know about it. There aren't really good ways of surfacing that information, and even when you try to surface the information, setting aside legal issues like gag clauses, where a provider can legally prohibit a payer from releasing their rates, when it does filter through to the consumer, there's a lot of research that if patients are told, well, you can have a $10,000 procedure at hospital A or a $15,000 procedure at hospital B, they will associate the $15,000 procedure with better, more care. And again, because even despite the transition to high deductible health plans, when things are that kind of ticket price, the reality is the consumer is not being exposed to a lot. To any of that variation in price. So it's definitely tricky. I'm personally, I'm surprised that employers are not more up in arms about just the rampant price variation that exists for the same services. I mean, to go back to my C-section example, that's a relatively discrete population of employed working age women or spouses of working age folks, and 4- or 5-fold variation, even if you factor in that, sure, San Francisco is more expensive than El Paso, it still doesn't seem to make sense.
I just put a finer point on something I was talking about, right? And I think you brought up earlier, right? I mean, the most sort of one of the most egregious examples of this sort of difficulty in pricing, right, is balanced billing, which clear is you go to a hospital, let's say you have an accident, you're still conscious, you get to the hospital, and it's in network, life is grand, they treat you, go home, and 6 months later you're back in the hospital because you had a heart attack because you got this huge bill from the doctors. Because it turns out that all the hospitals in your network, the doctors aren't. So there are a lot of, I mean, this needs to be solved by someone, but I think this goes to your point that expect consumers to be able to say, okay, hospitals in, who's the emergency room practitioner, are they in the network? That's a really sort of just unrealistic to think that consumers control that kind of pricing mechanism.
I could not agree more, because that actually, in many cases, is an example of somebody who's tried to be an consumer. When you talk about consumerism in healthcare, think of somebody who goes on to an exchange or the cafeteria plan with their employer, looks across their plan options, assuming they have them, picks something that they can afford the monthly premium. Their PCP is in network, and the formulary contains the drugs that they've taken, okay? Like, that's a relatively sophisticated act as a healthcare consumer. You're trying to do the right thing, and, Kyle mentioned, death by 1,000 paper cuts earlier. I mean, the U.S. healthcare system is death by 1,000 paper cuts, even when people try and do the right thing, and then they end up in hospital for an emergency through no fault of their own, and they end up with a $10,000 or $15,000 bill. I mean, the industry as a whole, and I mean every single actor in the industry, I think needs to take a long look at themselves, because, we are not providing anything close to a consumer-friendly or a consumer-centric experience. The entire healthcare system is a giant game of gotcha.
I think
Even got Marty Gaynor, who is, for those of you who don't know, one of the best and most rigorous health economists, has just done groundbreaking work. And a couple months ago, he's on Twitter talking about how he got hit by surprise billing in his family. So,
And I think surprise billing is also, and I think healthcare billing in general is also an area where competition really breaks down. I mean, even in a market that's not consolidated, if you're suddenly unconscious or you've just gotten in a bike accident, as one of Sarah Cliff's profiles in her Vox series on ER bills did, you're not going to be able to choose, and competition is not going to work for you. So I think consumer protection is really important, as well as maintaining competition in markets. I want to take up the last 10 minutes here to open up to audience questions again. Diane will have the mic here. Again, please wait till she gets to you, and let us know your name and affiliation. I see one question there in the back, and then one in the front after that.
Carl Polzer again. This is a question in the form of a hypothesis. And it's based on, I've been a health policy analyst around here for 30 years, and doing a lot of work on health insurance. So when you look at the bargaining between the insurers, as you call them, and the providers, mostly it's not insurers. First of all, it's TPAs, third-party administrators. Less than, in the private insurance market, most of the employers self-insure. So the TPA is just paying bills. They're not even taking risk. When you look at their incentive, so they're on one side of the bargaining table, and versus the provider side, everything that if the providers come back with 1% more over inflation, they keep it. They get a bigger car, they get the bigger fund balance. If the bargainers on the demand side come back with a little bit crummy of a deal, they get paid about the same, because they're paid basically a slice of the whole pie that they're representing. So in the long run, they have the same incentive as the supply side. So in other words, if the bargainers for the employers succeed in reducing the cost 1% a year under inflation, they're going to make less money in 10 years than they are this year.
Sorry. So the question is.
But anyhow, so the question is the incentives. Even if you didn't have this consolidation, we don't have the same adequacy of bargaining on the side of the consumer, who's represented by the employer, and then these insurers and TPAs as you do with the providers. There's weaker incentives. It's uneven.
So I guess the question is, do employer-sponsored plans that have a third-party administrator, in other words, the employer self-insures, have different incentives than insurers who actually are bearing the risk?
So, you know, I think TPAs would probably vigorously dispute your hypothesis and argue that they, you know, work really hard to negotiate the best deal for their clients. But you know, your point is right. Like whatever, you know, the commission on $100 million of business is less than the commission on $110 million of business. We did. The research is a little bit dated. We did look at. We can distinguish between TPA covered lives and fully insured lives in our database, and so I'm delving deep into my aging brain here, but we did stratify according to those two populations, and we didn't actually see significant differences in spending. I can't remember if one was a little bit higher than the other, and also it may have changed more recently, but you know. Yeah.
All right. So yeah. So I think there's different rules. I think I think the prices in healthcare really are it's not a consumer good. It's really up to the insurers to negotiate prices on our behalf, which is one of the things that makes this market really complicated. There's a couple questions here in the front.
Yes, thank you very much. When I was in law school, I had professors who used to say, worry about the definitions. Talk about the definitions. In healthcare, the definitions are codes. And when you talk about surprise billing, that's kind of a big issue. But lots of people are surprised every day because when they get the bill, it's been coded one way, and the coding has resulted in a certain cost that may or may not be covered. So the codes are the fundamental to the pricing. Correct? So I wonder, among you, has somebody really tackled the role of the coding within the pricing and the antitrust concerns?
And ma'am, do you mind sharing your name?
June O'Connell.
Great, thank you. Does anyone want to tackle that first?
I mean, I can take a shot of it. For better or for worse, coding is at the bedrock of our system, and it's at the bedrock of our system because every payment is linked to a code as opposed to a clinical reason. And again, it just comes down to fundamental economic incentives. If you have a choice of 5 codes, particularly in a fee-for-service system, ranging from $50 to $150. I'm thinking of E&M visits, like low severity to high severity. Over time, we've seen a secular trend towards many more people being coded with higher severity E&M visits. Now, that could be that people are actually getting sicker. It could be that providers were historically undercoding their patients, or it could be that they see that they're leaving money on the table in certain instances, and they have consultants or electronic health record software telling them to how about this code instead of this one, and it leads to the situation that you're describing. How it gets fixed, I don't really know. We struggled enough as a country and as an agency. I still have the scars transitioning from ICD-9 to ICD-10 years after the rest of the world. So taking on coding in a more fundamental way seems like it could be tough.
And what I would add, and I think this goes both to this question and the last question, is until we adopt a different system with some sort of price regulation, as Topher suggested, we are left with competition as the mechanism. And so although it may not be a good solution, it's the only one we have. And I think sometimes we underestimate that if you get rid of competition, it's easier for hospitals to start upcoding. And if there's less competition in the insurance market, it's easier for them to sort of have an agency problem. And I think that's one of the things in the competition world we've sort of missed. is understanding that there are lots of ways people can use market power that is actually hard to address from an antitrust standpoint, and why actually preventing concentration is even more important.
And I think that also builds on the point that's been made earlier too, that to really understand healthcare pricing, you have to understand both the insurers and the providers and how they interact, which there are some obstacles to doing at the federal level. We've got time for one more question.
Over there on the left was, yeah. Oh.
And Paul Heldman with Heldman Simpson Partners. I'd like to get your opinion on the sort of the feasibility and challenges and utility of a couple of ideas on getting more transparency in healthcare prices. First, the Trump administration sort of snuck into a regulation a couple months ago, the idea about requiring, either through regulation or legislation, hospitals and insurers in the commercial market to disclose actual reimbursement rates. I assume that would be by local market. So I want to get your sense of that. And then also there's been discussion on the Hill about sort of requiring employers to disclose all their claims data. And I'm told that that actually happens in some states. So if you're familiar with that, I'd like to know sort of how that's worked out in those states.
So two things. I'm definitely aware of the recent administration proposal. In frequent other forums, I've described it as audacious. I guess I'm a little too cynical these days. I'm not. I think it will. The most likely outcome is a significant amount of legal activity around that. Because that really is the kryptonite of the healthcare system. Getting to your other point, about 13, 15, 18 states have passed legislation setting up all payer claims databases in which employers and other payers are required to submit data to the APCD. Generally a positive development. I will say that there was a Supreme Court decision a couple of years ago that set back the advances fairly significantly when I believe it was Liberty Mutual sued to, that went all the way to the Supreme Court, Liberty Mutual arguing that as an employer who was self-insured, they were not required to submit their data to multiple state APCDs or any state APCD. They prevailed in the Supreme Court, and that actually preempts a lot or all of existing state legislation. So now many state APCDs are in a position where they're sort of begging employers to ignore the Gobet ruling, focus on the greater good, and actually on their interests. I think it's a little bit self-defeating for employers to choose not to pool their data with other claims data so they could actually understand more about price dynamics, but some of them are asserting the right not to do so.
Thank you for your questions. And I think we're out of time now, but I want to say a big thank you to Commissioner Slaughter, to Niall, to Michael, and to Kyle for joining us today for what's been a great discussion. And I hope to see policy changes soon in this area. Keep up the great work. Thank you.